Okay, I think we're going to get started. Good morning or good afternoon, and welcome everyone to the 2024 webinar series for the EFPC. For those of you who are not familiar with the EFPC, we are the European Forum for Primary Care, and we bring together stakeholders within primary care. So these are healthcare workers, policymakers, researchers, to discuss the organization of primary care and how to achieve the best outcomes and healthcare for populations in Europe. Today, our webinar will be on social prescribing, unlocking primary healthcare's full potential with the support of the community. And we have a lovely panel of speakers for today. Our first speaker will be Dr. Andrea Biscaya. He's a family doctor, researcher, and president of the National Association of Family Health Units. Then next up will be Julia Hotz, a journalist and author of the book, The Connection Cure. The next speaker will be Dr. Cristiano Figueiredo, a family doctor, PhD candidate, and co-founder of the Portugal Social Prescribing Network. The next we have Marcello Bertotti, reader in community health at the University of East London, researcher and editor of the book Social Prescribing Policy, Research and Practice, Transforming Systems and Communities for Improved Health and Wellbeing. And then finally, we have Professor Sonia Diaz, professor, researcher, and director of Nova National School of Public Health and the co-founder of the Portugal Social Prescribing Network. So without further ado, I'd like to hand over to Andrea to start our webinar for today.
Hi, everybody. I just want to ask if everyone is seeing my slides now.
Is not in the right mode. It's still the all of the slides.
Okay, but I think I have some problem here. But is you are able to see the slides even?
Yep.
Okay. Well, thank you very much for the EFPC, Diederik and Cristiano, and all of you to inviting me. I think what I'm going to try to do right now is to give some context to the social prescription and see how our association is the way that our association is doing on this path. USFIN is a multi-professional association. We have mainly doctors, nurses, and clinical secretaries, but also some more professions. We are now in Portugal. We are now facing a lot of problems. For the first time, we are facing privatization of primary care. And we are trying to deal with that. But this is only the part of the context. What I'm going to try is to make some bridges with the path that we did in Portugal and on this area. We had the Porto. 7 years ago, we have the FPC conference of the FPC in Portugal. The title that we choose, it was the citizen voice in primary care, social commitment to health for all. I think if you do that conference nowadays, I think we can choose something like that: social prescription, community action in primary care, a social commitment to health for all. And that's the issue. If you want to reach this goal of health for all, I think we need to follow different paths that we did in the past. This is what well, the focus of the USF of the health units, primary health care units in the past. We focus a lot on patient and family health units.
The slides are not changing. I think is a
well, so I'm going to try.
Maybe if you try again. Like
Is doing? I'm moving?
Let me see. Try to
do it again. Sorry.
If you want, I can try to do it. And is it okay?
Are you and now?
Still the same.
Okay, Christian, if you can help me.
I'll try to do it now. Okay.
Okay, sorry.
Okay. Is it working?
Yes. Okay. Thank you very much.
So,
okay. The next one. This it was the Porto conference, and let's just go to the another one, to the next one. This is the well, the focus on patient and family health units. We'll next we'll we have this more approach on primary care and the national health service with the hospital setting also. Next. But also the public sector, the schools, the social security, the work institute, the local power organizations, but also next, and also the social and next one. Sorry. And also the putting together with the social sector and the private sector for profit. And this is how the new bottom-up national service programs focus on patient health needs. The next one. And this is important because if you only focus on the healthcare on the healthcare issues, we also only targeting 20% of what is needed to primary care and for health. If you don't put it all together, we are missing the others 80%, health behaviors, physical environment, social economic factors. And with social prescribing, we can bring the national service to the missing 80%. The next one. We did a lot of things in our association. This is our book with our plans for the future. 3 years ago, we put one of the pillars on social prescribing network to facilitate the development of partnership with community resources to respond to patients' social needs and act on the community social determinants of health. The aim was to establish a true proximity network concept. Next one. And then we did a lot of also training. We have an academy, the Academy for the Future, as we call it, and we had some courses on social prescribing, powered up. We also with the Nova National School of Public Health. The next one. This is some of the photos of some of the training program. And next one. And last one. Well, we are all familiar with this picture. Well, we must put that bridge to Alma goals that is very clear that in addition to health sector, all related sectors and aspects of national and community development, in particular food, education, housing, public works, and other sectors, and demands for the coordination of efforts of those sectors. Also, the next one, we have also the Astana with put another focus on that. We will address economic, social, and environmental determinants of health, and aim to reduce the risk factors by mainstreaming a health in whole policies approach. We have also more recently the WHO also put that focus. If you don't only focus on on the healthcare units and healthcare function, we are going to miss the whole goal, and also we want to be able to provide a long-term response to a wide range of ever evolving public health needs and challenge. And for instance, that's the last measure. So prescription, we really agree and believe that can unlock primary health care's full potential with the support of the community. This is our National Day of Social Prescription, which is the 4th of March. This is one of the pictures of the health national directorate of Portugal, and all the activities that that Portuguese government is also trying to reach with this on social prescribing. Thank you very much.
I hope it worked with the slides.
Yeah, that was good. Thank you very much. Next, we have Julia Hotz, who's going to be speaking. So if you'd like to share your presentation.
Sure. Hello, everyone. I should say good morning because I'm based in New York, so it's a little early for me right now. Apologies, but lovely to see all you. Very grateful for all the work that you've been doing in this space. So I'm just going to talk for a few minutes now about how I'm connected to social prescribing, which I realize I don't know if it's been defined yet properly, or if we'll get into that. But what I wanted to talk about today was some examples, some evidence, some qualitative evidence, and some quantitative evidence supporting social prescribing. So without further ado, can you see my screen okay? Yeah. Okay, great.
It works.
Okay, so once upon a time, 2 years ago, I had this chance to start writing a book about social prescribing, really sort of for mainstream readership. So, really getting to the stories of how social prescribing actually works. And I was very fortunate to meet with some of the leaders in of social prescribing in Portugal, who you'll hear from shortly. But, I thought I'd start, or in this sort of limited time, tell you two quick anecdotes that I came across that I think really show the power of social prescribing. So, one comes from this woman named Amanda. And Amanda is this lovely, bright eyed researcher. And she also happens to be struggling with clinical depression. She tells me about her life, and it's just been a really rough couple years for her. She lost her mother. She found out her husband was having an affair. So they got divorced. She lost her job. She had to move to a new place. And this was all in the middle of the pandemic itself. So she was diagnosed with clinical depression, put on the maximum dose of antidepressants. And when she's describing what that feels like, she said, "It feels like you're enclosed in a deep, dark helmet, and I can't escape these deep, dark thoughts." Okay, but so then Amanda is prescribed a spot in her local chill therapy course. And what is chill therapy? It's all in the name. It is a course in which she is learning how to navigate open water sea swimming in the cold, cold months, mind you. It's an 8-week course. She's doing it with, other sort of women in her age group. Um, And you'll see them in a sec, but that's a little screenshot from when I had the chance to get in the sea with them. That's Amanda there in the yellow shirt. And by the end of it, she ends up going from the maximum dose to the minimum dose of antidepressants. And she tells me what it's the sea swimming do to her. It's helped her to clarify her mind. It's stopped all her bad thoughts, and it's helped her life become bright again. And so Amanda's not alone. There's actually a good amount of evidence now to support sea swimming as an intervention for depression and anxiety. This feasibility study showed that it significantly reduced the severity of anxiety and depression symptoms in people who had tried this course. And it belongs to a larger body of research suggesting that exercise, moving our body, happens to be really effective for some of the symptoms of depression. We know that movement increases our production of serotonin, the chemical strongly associated with mood. It helps us release our endorphins. It can stimulate our dopamine pathways. So that's just one story to show how instead of or to complement her pharmaceutical antidepressants, a movement prescription also complemented or also served as an antidepressant for Amanda. So I'll tell one more quick story. This is about Marianne. She's the one in the purple sweater here. Marianne is diagnosed with dementia, and it was a real shame because, you know, as is often true with people with dementia, she lost her ability to drive, and she absolutely loved socializing, but she was sort of stuck at home with this husband who did not want to talk to her, did not love social prescribing. She hated sitting still. So what does she gets prescribed? She gets prescribed a spot on this care farm. It's called the Astad Impulse Center. And this is in Norway, by the way. The other example was in the UK. And what does she do there on this farm? She comes there 3 days a week. And she, as you could see, those are some of her fellow farmers. She has lunch with them. She goes on walks with them. But as the name suggests, she's literally doing farm work for them. So by the end of this, dementia is one of those conditions. Unfortunately, there's not so much of a pharmaceutical cure, but she says her quality of life really improved. She's able to come here and talk. She's able to come here and walk. She's able to come here and feel like she has something she could do. And she says simply, I come here and I enjoy my days. And I'm not at home thinking about how I have dementia and have lost so much of my life. So this again is supported by a good amount of data. There's a famous study in which from Dr. Ellen Langer, who compared what it was like in a nursing home of residents who had a houseplant in their room and had to take care of that houseplant versus those who just sort of had all of their needs taken care of, didn't have the houseplant. They found that this very simple addition increased the residents' alertness. It made them more active. It improved their general sense of well-being. Later studies found that fewer people in the plant group had died. I mean, it really served to improve people's health in a big way. And there are some larger studies that show this too, that when we serve, when we feel we have some kind of sense of purpose, this is associated with decreased mortality. In other words, stronger purpose in life is correlated with decreased mortality. So, wrapping up here, it's very clear social prescribing is good for us. How is healthcare getting on board? Well, as I believe my dear fellow speaker, Dr. Marcello, is going to speak about this, practice is spreading all around the world. It's now happening in 30 plus countries. We know from the data that it improves the health, it improves the self-esteem, confidence, mental well-being, positive mood of patients. It reduces anxiety, depression, and negative mood. We also know that this reduces reliance on health care over time. Some studies in the UK found that it reduced accident and emergency visits. It reduced reliance on primary care services, which I'm sure this group is very interested in. Evidence suggesting that, for every pound you invest in social prescribing, some pounds come back. Again, this has to do with the reduced pressure on healthcare over time. And it's not just the UK. Even though this practice started in the UK, we're seeing similar results in Canada, less pressure on healthcare. Where even it's spreading to the United States, where we have a very different insurance system, a very different healthcare system. This study, for example, of a culture prescribing pilot in Massachusetts had not only these lovely anecdotes from patients, but also from health providers who said, for me, this feels like a chance to prescribe beauty to my patients. Again, it's spreading in the US. It's even starting to get health insurance companies on board. There's an example now of a private insurer, Horizon Blue Cross Blue Shield, that's actually covering the social prescriptions of their members, based again on all of this evidence. Yes, and of course, Portugal is doing this. I'm sure Sonia and Cristiano will talk about this, but based on what I saw in Portugal, I was really impressed with the way that the pilots serve a very wide range of population needs, also offering a very wide variety of prescriptions, from a spot in local senior university to language lessons and a career mentoring program. And the way they've been able to do this by using the social worker, again, I'm sure Cristiano will talk about this, and the way that, thanks to the efforts of Dr. Sonia Diaz and her team, it's been really rigorously studied and co-designed from the beginning. So I think that's my time, but if you want to learn more about this book and some of this research, there's this website, socialprescribing.co. So thank you so much. And I will pass now to, I'll pass back to Robin, because I'm actually not sure who's next. Thank you.
Perfect. Thank you so much. Next up, we have Cristiano. So if you'd like to take it away.
Yes, let's do it. Just give me a second. I hope it works now for me. Yes, it will. Just confirm if it is okay. Is it working?
Yeah, perfect.
Okay, so social prescribing is, we can say, it's kind of a new trend, but you can find old papers about it. And one of the very first papers about social prescribing is this one that says social prescribing in general practice, adding meaning to medicine. When this paper was released, I was still a medical student, so I was not in clinical practice. But very soon, when I started engaging in clinical activities, I realized that most of the real issues affecting life and well-being of our patients were not the typical biomedical symptoms and signs and diseases we are trained as doctors and then as a GP. I always felt a very strong connection with healthcare in the community, so that was the reason why I decided to be a family doctor. And one of the big questions this paper states is, can or should we try to do more of the few minutes of a GP consultation? There is this feeling that very soon you are not going to the root causes of the symptoms and diseases of our patients, and we are missing something. There is a missing. This feeling, actually, it has been recognized by several associations. Firstly, for example, the World Medical Association in 2015 said that doctors working at all levels could make a significant impact on health inequity through action on the social determinants of health, for example, through social prescribing. Then, more in the primary healthcare field, the Royal College of General Practitioners from the UK said in 2018, part of the 10 high-impact actions to reduce the demand on primary healthcare, the idea of introducing social prescribing initiatives such as the social prescriber role or the social prescriber link worker, accessible to all practices, to all clinics, and a database of relevant local services. So once again, a medical association putting the focus on the social determinants of health, and actually calling on the health professionals and doctors to act on this information. And then lastly, the World Health Organization very recently mentions that there is an opportunity for member states to utilize social prescribing to improve social connections, social determinants of health, and physical and mental health outcomes. So as a doctor who believes in this and witness this in practice, I feel kind of it's good to see that international organizations recognize what we face in clinical practice and try to drive us to look at the social determinants of health. And the main reason is this, like the root causes of premature poor health are more and more known. We know that many of so there is a increase in the longevity, there is a rise of chronic conditions, there is also pressure on mental health, and if we try to understand what's the real reason behind it, we find a lot of social factors, socioeconomic factors that can cause long-term chronic stress, leading over the years to the chronic conditions we treat and we deal in primary health care. We may speak about lack of control over work and life, poverty, social isolation, problems of unemployment, and living in areas with lack of safety, and so on. And these kind of situations, what we feel in clinical practice is when we work in social deprived areas, we have to deal with more chronic diseases, higher consultation rates, more out-of-hours calls, longer consultation times, higher cost ratios, and it's not surprising to say more burnout. So it's usually difficult to maintain health workers working for long years in the deprived areas because the stress is they are under stress, under high demand. And the way I look to social prescribing is really as a complement to the medical model I was trained to, and it really can change the way we practice healthcare, and really can put into practice the biopsychomedical model you always try to pursue. So if we manage to add social prescriptions to the ongoing medical prescriptions, in many of our patients probably will provide better health care with better results and with a more holistic and personalized approach. We are addressing mostly the unmet needs of the biomedical traditional model. And through the social prescribing, I believe it can unlock the primary healthcare full potential with the support of community. I'm bringing to you some stories. Imagine a teenager is facing low mood, elderly patient feeling lonely and probably with a little bit of dementia symptoms, and a younger patient, adult, facing obesity and low mood. All of these patients are regular into health professionals. They go to primary health care. You are the first door to the health system. And if you are able to set up a system, a clinical pathway that connects these patients with a link worker that has a very good knowledge of all the activities going on in the community and knows how to connect these patients with the right activities and services in the community, you really can change the clinical pathways of primary healthcare patients, adding something else to the biomedical model. For example, for this teenager, probably help him to engage in some local sport group like football, or help him to go camping with some group, some community group. And we know this can maybe make him away from the social media, from the screens, and improve his mental health issues, increase his self-esteem. For this elderly lady, why not trying to join some Tai Chi classes, exercise classes adapted to his age in the community, promote some visiting to museums. We know art and physical activity improve the functionality, the movement, and the mental health, and also the cognition of elderly people. And in this last patient, the option, for example, for someone obese, to refer someone to healthy cooking workshops in the community, or imagine this patient is facing COPD, he was a long time smoker. Why not joining some core to sing and to try to improve his respiratory status. All of these can be called a social prescription, acting on the root causes of diseases and taking advantage of the resources and activities in the community. There was a very recent survey about the awareness of general practice in Europe about social prescribing. And when we see the results, okay, in most of the patients, GPs, family doctors know about social prescribing, but still, still a few countries don't have a lot of the professionals don't know about these terms. So it's important to raise awareness of what means social prescribing and how it can change your practice. Nevertheless, when you ask to the GPs if they are referring patients on a routine basis through a formal system to access activities and groups in the community, even in countries where we don't hear about social prescribing, there is some activity going on. Okay, so this is also interesting data. So I'd like to ask you: do primary healthcare professionals need social prescribing? I believe yes. Okay, primary healthcare professionals may benefit from social prescribing as it provides creative options to address patient complex needs, bridges the gap between primary healthcare and voluntary sector, creates referral pathways to address the social factors and enhance well-being, complements the pharmaceutical treatments with lifestyle-based interventions, potentially reduces the health service use and workload, promotes professional satisfaction, and very important, prevents overdiagnosis, overtreatment, supporting the idea of quaternary prevention, primo non nocere. Another way to look at this: does social prescribing need primary healthcare professionals? Yes, social prescribing requires primary healthcare professionals to buy in the social prescribing well-being holistic approach. There is no social prescribing primary healthcare professionals are not engaged in the model. They are very important to identify the patients with the social, emotional, and practical needs that can be addressed by social prescribing. They need to engage referring the suitable patients to social prescribing link workers or to activities in the community in a direct model of social prescribing. They need to engage with social prescribing services and activities to know about them. And a lot of times in bottom-up approach of social prescribing, support the implementation in their specific local healthcare context. That was what happened in Lisbon when I started the implementation of social prescribing back in 2017. It was a bottom-up movement. It was the idea of a social worker and a family doctor to introduce social prescribing in Portugal, adapting the existing service. And it's very important to raise awareness among patients and other healthcare professionals. It's very common. We identify the right patient for social prescribing, but they don't know what is it. They are very suspicious about the idea, and they still don't trust this clinical pathway. And why not stay informed and get additional training on social prescribing? You have some courses on WHO and other universities going on. So should we define a common agenda for social prescribing and primary health care within the European Forum for Primary Care? That's the question I do. The European Forum for Primary Care connects all the professions working in primary care and all the countries in Europe. I think it's a very good common agenda for the future. Thank you so much.
Thank you very much, Cristiano. Next up, we have Marcello. So if you'd like to share your presentation and continue. Thank you.
Yeah, just bear with me a second. And just a second, yeah? I'm just trying to... I can't, well, it will work. Just a second. Can you see it, yeah?
It's working, it's good.
Yeah. Hi, well, thank you for inviting me, first of all. It's always nice to talk to GPs. In fact, is the real reason why I got into social prescribing is because of a GP here in London who basically basically convinced me quite earlier on of the importance of social prescribing for GP for primary care. So it's quite important for me to actually spread the word, if you like. So I'll be talking about the rationale, the current evidence in the future of prescribing. I mean, some thoughts from my perspective, and of course from the evidence around. So as was introduced earlier, we wrote this book, which I edited on social prescribing. These are basically 28 people were involved in writing this book, and I coordinated the writing of it, basically. So it draws upon research, policy research and practice in several countries. England, Wales, Ireland, Portugal, of course. There's some of the people writing. One of the chapters are on this call as well, of course, Cristiano and Sonia and others. So yeah. Anyway, you're welcome to purchase, of course, if you're interested in the topic. But I'll get to the presentation itself. So why social prescribing in primary care? I mean, I try to kind of really get to the key reasons. There are probably others, but that concern primary care more in practice. I mean, so demand for GP visit is growing internationally. So and is driven by an aging population, comorbidities, mental health issues. I mean, as Cristiano and Andrea and Julia to some extent already mentioned, that there are all social determinants of health as well, which have an impact on these. So, but just to say that, you know, between 2015 and 2050, the proportion of the world's population over 60 years old will nearly double. So, and the population over 80 years old will treble. So we will have basically an elderly population which who will need support, medical support, but non-clinical support is also particularly important because, as Cristiano mentioned, the elderly lady joining yoga classes or Tai Chi or other things is an important part of keeping person active, physically active, and therefore away from hospitals as far as possible. So, and away from primary care too, as far as possible. Also, those people tend to be lonely, fortunately, and therefore might also visit primary care, not because they have particular health problems, but because they feel lonely and socially isolated, and they need to talk somebody to talk to, and the GP is often the person they can talk to. Anyway, and then the other point about the importance of social prescribing in primary care might be also the average consultation. So some research looking at 67 countries found that 50% of the global population spend less than 5 minutes with the primary care physician. So in other words, again, is what Cristiano mentioned earlier about the time GP spend with patients is shorter and shorter because there are more and more people. So the money is higher, the time becomes shorter and shorter. And so the help of a social prescribing link worker or social prescribing in general can alleviate that problem, can in essence support the GP to provide help for those patients. And the reasons for GP consultations are not only about health, but also social. Again, Andrea and Cristiano already mentioned this, and there is evidence that that's the case. So about 20% of the time GP spend in GP visits are mainly due to employment, housing, debt, and social isolation. So are not strictly health related or clinical related. So again, social prescribing, as mentioned already, can help with that. And of course, this is a problem, even more of a problem in areas with high health inequalities. I mean, you might be familiar with the work of Michael Marmot Sir Michael Marmot, she said, in the UK, where life expectancy in the most deprived areas is 8 years lower than in the least deprived areas. So there is, again, even more need for support in those areas, particularly around employment and housing and debt and so on. So the result is healthcare expenditure is going up globally, and quality of support is declining. So there is an issue. How can social prescribing, how might social prescribing help? Again, it's what I just said. In a sense, the link worker can help GP who have very little time and might not be familiar with the range of non-clinical support available locally. So this goes to the point that although GPs are very knowledgeable people and very smart people on the whole, they might not know what non-clinical support is available locally. And the link worker can help with that, having the knowledge of such activities. So it makes sense to refer to that link worker. The link worker is also important because tries to look at what matters to me. So what tries to in a sense meet the needs of that person, and these needs might be health and social. So, for example, in the UK, link workers can spend between 6 and to 12 sessions with people, so they have more time and to explore a variety of issues. Although there is the models vary considerably in terms of the way the support is provided. And then, yes, I mean, link workers sit between different other roles. People might ask, well, there are other people who support patients, people with problems in general, social workers, youth workers. I mean, the research here is not particularly clear. But there are differences that we picked up over the projects, different projects, including the project with Portugal, COPE project, which might be talked about later. But essentially, link workers have their own role within this wider other roles. We can talk about it maybe a bit more if you ask me questions about this. Okay. So what's the evidence on effectiveness? I need to say, first of all, that social prescribing is growing. So there's been a 2023 report published with the World Health Organization here from the UK, which shows that social prescribing is growing in at least 25 countries, all across the globe, really. And then the evidence on the benefits on users, so the benefits of social prescribing on health and social outcomes, is still mixed. It seems to be mixed, and it's been mixed for a while, to be honest. The systematic reviews have concluded that many positive effects have been found on. I don't know why there are question marks there. Apologies, but anyway, found on mental health in particular, on loneliness, but controlled studies not find such positive effects. And the rigor of the evidence is limited. That's the conclusion of a fairly recent systematic review, but that's not the only one. There are other systematic reviews that conclude very much the same. So essentially what they're saying is that randomized controlled trials, there are only a few which are rigorous enough, and those have found some positive effects, but not as much as expected, perhaps. And yet the qualitative evidence is much more positive, and there's a very wide literature on this of qualitative evidence and mixed studies, which shows on the whole quite a positive effect, particularly on loneliness and mental health. And the economic evidence, the economic evidence, I just show one source from Polly et al., which conducted a review of the economic evidence, particularly focusing on the UK. And here the 5 out of 7 studies have found an increasing decline in the net reduction in health and social care usage, although 2 studies have found an increase in costs. So the majority found an improvement in reduction in costs, but 2 studies found an increase in costs. A regression modeling study found that users with high engagement with social prescribing generated the greatest cost reductions in care costs. So that what it means basically that people who have are supported the most create the greatest reduction in care costs. And also other studies have found that those who have higher needs at baseline could produce the higher savings. So in that case. So finally, what is the social prescribing? Where social prescribing is going is there's greater experimentation with different models across different areas and different target groups, from the elderly, from different with cardiovascular disease, with diabetes, with different target groups, young and old. And there is a tendency in some studies to have a greater involvement of social prescribing user in designing social prescribing models. The greater involvement of the third sector as a way to access groups that might experience more severe health inequalities. In the UK, the policymakers have introduced something called proactive social prescribing, which tries to use other models to slightly away from primary care to involve people, particularly from ethnic minorities and migrants. And finally, a greater focus on prevention. There is some kind of talks and debates about health creation. So basically tackling the problem even before it gets to primary care, essentially. That's what this is about. So and shifting, of course, also resources towards more health promotion and that kind of area. And there are ongoing issues in the way the development of social prescribing. For example, talking about the services, the community, are there enough community services to meet the demand? And do they receive enough resources? So if we want, if we do agree that social prescribing is important, then the third sector, the voluntary sector, those people and organizations delivering activities like yoga and Tai Chi and others need to be properly resourced, essentially, because this is not necessarily happening at the moment, or not everywhere anyway. And I would stop there because I think I've gone on for a while. So I'll skip that last bit, but happy to take questions. And there's the references. And that's it, really.
Great, thank you very much.
Get out. Yeah.
We'll proceed to our last speaker for the afternoon, Sonia Diaz, and then afterwards we'll take a few questions. So Sonia, if you'd like to share your presentation.
Yes, hello. Thank you so much for the invitation. It's a great pleasure to be part of this seminar, and just me. So can you see my slides, please?
Yes, it's working.
Okay. So, like I was mentioning, it's a great pleasure to be part of this webinar and taking the advantage of being the last presenter. I was asked to also talk a little bit more in a specific case and in fact describing and sharing with you a little bit of what has been the movement in social prescribing in Portugal. So part of the team that are today here is really involved in social prescribing in Portugal, mentioning Cristiano, but also André. So we started in the beginning in 18 and trying to implement the first pilot project in a health unit in Portugal, and I think it's quite interesting because it also challenge us to as academia working in a different way. So our involvement, it was not so much only in producing evidence and doing science as academics are normally used to do, but we tried to be useful for a team of health professionals that wanted to implement a new strategy in Portugal and trying to see how the evidence that we were producing during the process of implementation could in fact help to improve the initiative. So this was the first initiative in Portugal. Then we applied to the health award and we won the winner of the Sustainable Health Award. It was really interesting, and with that we was also able to implement the project in the second health unit. Then we had the COVID that was a really barrier in our country because we started to work very strongly in social prescribing, and then with the COVID it was a period that the health units, as you can understand, and the primary health care were not able to cope with social prescribing due to the pressure that the services had with COVID. But during that time, we took the opportunity to do a lot of social prescribing webinars, awareness of the initiative, capacity building of health professionals and other social professionals. And so we tried to work a lot in dissemination and capacity building. Then in 22, it was important, although we still facing challenge, but we were able also to see the resolution of Assembly of the Republic recommending the development of social prescribing in projects. In 22, we increased a lot the number of family units that started to implement social prescribing initiatives. And quite interestingly, last year, municipalities and the third sector were also very much involved in the projects, and it was interesting, mainly municipalities that started to understand that probably they could also be an important player and assume the responsibility and the coordination of several projects linking with the primary health care. And this here, but I will explain a little bit more about this. But just to give you an overview of the flow that it has been developed, this year we were able to launch the Portuguese Social Prescribing Network. So, as we have been academia, but also involving a lot of health professionals and other stakeholders, and namely Cristiano, as no one's know, we decided that it is important to organize and systematically study social prescribing in terms of process, but also the impact in our country. So we are establishing at the moment the Knowledge Center for Social Prescribing at National School of Public Health from Nova University. And what we really want is to support organizations nowadays across different regions of Portugal in not only monitoring and evaluating the impact, but mainly trying to help share from the experience that we have learned, but sharing, like I was mentioning, sharing our experience in terms of design and trying to see what will be the best type of initiative in the specific context, but also helping in studying what will be the best strategies for an effective implementation of the project. So we have been working together with different organizations. What we have also learned is that, in fact, social prescribing is also a very effective way of building partnerships and working in terms of intersectorality. And so this is something that we have also been working, and that's why we established also the Social Prescribing Portuguese Network. And we are also working in terms of knowledge centers and also as academia. We are very involved in trying to produce high quality evidence to support integration of social prescribing, health policies and practice in Portugal. We are members of the international network that Marcelo were also mentioning, but it's quite important also to start creating this high quality evidence in our context. So just to give you an overview of what were the social prescribing movement, but also to give you an idea of the state of the art at the moment, it is quite impressive the excitement, I can say, about social prescribing initiatives. So we started, as we mentioned, with health units and primary health care, but at the moment always linking with primary health care. But nowadays we have several different governance models, and what we mean is that several times it's not only the primary health care that is the coordinator of the project, but nowadays we are trying and testing different governance models. And for example, we are working a lot with municipalities that are assuming the coordination of the project, linking with primary health care. But we are understanding, for example, that probably the municipalities, because they have also local policies and probably more resources, financing, but personal resources, probably that could be a good governance model, at least from our country. So nowadays we have a lot of initiatives spread in different regions of Portugal. That's quite interesting, because nowadays we are starting to have evidence in completely different contexts. Big cities, but also small cities, rural areas. For example, we have completely different specificities in health profiles across countries. So we are now testing, for example, in a very rural and small areas, social prescribing projects for elderly, for example. So we have also a lot of patients referred and more than 100 partnerships. We have also several challenges, because it's not easy to start working as academia with health professionals and other professionals in order also to collect data. So Marcelo and also the PhD students like Cristiano, it's very, very important to understand what will be the most effective way of collecting data. So just to give you an overview of social prescribing projects, so we have this START project in the family health units in Lisbon. The first one, as you know, was with Cristiano in USF da Baixa. We are now also working in a huge project of cultural prescribing in a more rural and central area of Portugal, in Alentejo. we are, like I was mentioning, working with municipalities. We are starting now a new project in Cascais. That's a city near Lisbon, and it's quite interesting. For example, here in Cascais, we are going to work with a specific project that it's with users of healthcare that doesn't have family doctor. So we are choosing a completely different context to also test this approach. And then we have Vila Pouca de Guiar, that it's a very small city in Portugal. Then we have others proposals, and we have also that Marcelo has worked with us in a COPE project, that it's an European project that has worked also with another different group that was with nets, that was young people that haven't a project either in education or professional. And I don't have time to talk about this project, but it's probably the first one that we are starting to have strong evidence that with good results in social prescribing. And Cristiano, Marcello, sorry, that I was mentioning, is also part of the team. So now we are trying also to disseminate these results. So, like I was mentioning, we are now organizing Knowledge Center and inviting some experts to be part of this Knowledge Center. We hopefully has the Knowledge Center organized and working systematically until the end of this year. And we want, in fact, to provide technical and scientific consultancy, like I was mentioning, in several parts of the project, beginning with the design, the implementation, monitoring and evaluation, but also the dissemination of these initiatives. And this is something that is in the international network and the learning also with the other colleagues, that it's quite important that although we are very happy that we are increasing the dissemination of initiatives, it's quite important to ensure quality and to ensure that what we are calling social prescribing initiatives are really initiatives that has the concepts of social prescribing, but also the quality of its implementation, and then the collecting data for having evidence, because we really now need, at least in our national context, we really need evidence in order to be able to translate these initiatives for health policies and practice. So we are also working in training and skill enhancement, and I will talk a little bit about this. And also, like I was mentioning, the promotion of Social Prescribing Portugal network. So, like Marcelo was mentioning, and we have been also working at national level, but also in international network, in order to try to disseminate more evidence about social prescribing. So we have been working in publications, and the first protocol of evaluation of impact and implementation in the first project that I was mentioning with Cristiano and Luisa, we have published the protocol, and we are now trying to also publish data that we have, for example, regarding barriers and lessons learned. We have also been involvement in the global developments in social prescribing world mapping the initiatives. We have participated in the social prescribing policy research and practice that Marcello coordinate, and also very happy to participate also in the book that Julian has mentioned about social prescribing in the world. In terms of national context, and I'm so sorry because the manual is in Portuguese, but we launched the first manual to support the implementation of social prescribing, and it's in fact something that result from a lot of webinars that we were working with health professionals and understanding what are the main questions and the main key points for trying to design an implementation initiative. So we have been working in a guide, very practical
Quando
guide.
disse de ontem para hoje, ele disse-me isso que ia tentar fazer.
Sorry?
Hã?
Sorry. And then...
Eu não sei, Paulo, eu estou a dizer aquilo que me disse ontem, era do almoço, não sei.
Sorry, just a minute.
It's a participant.
I'm not sure what is happening, but I think okay. So I'm finishing, but just to give you an overview. So we launched in April the network. It involves professionals, mayors, health service users, policymakers, researchers. We were really happy because it was really well attended, and nowadays we are also finishing organizing the global social prescribing Portugal, and the numbers of the network is really important. Just to finish, to give you an overview of three new projects in social prescribing. One is that we are very, very lucky that we won a social prescribing project at European level to promote and improve access to health services and care services for people in vulnerable situations. And our team in Knowledge Center is part of the project that is coordinated by Charité, and it's 22 partners from 18 countries, and I think it will be also quite important to try to find international evidence about this. So we are going to be one of the partners and involved with the responsibility in co-creation and participatory approaches. It's one of our main tasks in this project. It will start in January, so we haven't started yet. And we all have also this week, so very, very new but good news, that at the national level we will also start 2 new projects. One is the green and social prescribing for children, and so it's something that we also would like to try to learn more about the experience of social prescribing for children. And another one also linking with the project of WHO, that it's linking the primary health care, but also psychiatric units to work in a project about motherhood and music in Portugal. And it will be, like I mentioned, a WHO multi-country intervention to prevent postpartum depression and improve maternal health, mental health. So it's good news, and I think our knowledge center, but also the social prescribing Portuguese network is in fact advancing a lot. And for me, it's really important, this kind of webinars, but also sharing a lot of experience. And Marcello and the other colleagues from United Kingdom International Network has been very important for us in terms of sharing good experience, but also sharing the challenge and jointly trying to understand how can we overcome challenge that we face. And I think that's also quite important to mention that it's a new initiative, so we really need a joint support in order to advance in countries that are starting the movement at the moment. So thank you so much for the attention. That I'm more than happy also to respond some questions. Thank you.
Thank you very much, everyone. Seriously, a panel of experts that have given us our talk today, and we really are grateful to each and every one of you for the valuable contribution that you have made. We are a little bit over time, so I don't know if there are any burning questions that anyone wants to ask. Quickly, maybe we've got about 5 minutes. Otherwise, everyone did provide their email addresses in the chat box. So if there are some bigger questions that you want to ask or some more information that you are looking for, I think maybe send a personal email to them. Also, just as I did put in the chat box, we do have a YouTube channel where all of our webinars are posted. So this one will be posted there by the end of tomorrow. I just need to edit it slightly. So yeah, thank you very much. And please join for our future webinars. We've got 1 or 2 still planned for the rest of the year. But first of all, we have our annual conference, which is starting this weekend. So we're quite busy. But yeah, thank you very much for joining, everyone.
Thank you.
Thank you.
Bye-bye.
Thank you.
Thank you. Bye-bye.
Thank you
Bye-bye.
so much. Bye.
Thank you. Have a good day. Olha.